body. Some are much more specific. Some of them, like this one about the chances of developing depression and underlying risk of mental illness, I think are pretty tenuous claims not backed up by a lot of data. And then others like this correlating the risk of heart disease and stroke is actually really, really clearly defined and shown in research over and over. And so where does this information come from? Where are the news media getting these ideas? There are kind of two different routes you can take in medical research, basically. The first one's kind of experimental science. I think it's sometimes what people think of as science more generally. So basically, in experimental science, the researcher is actually manipulating the circumstances of the experiment to try to see what can happen under particular circumstances. These tend to be kind of small-scale investigations. They're trying to demonstrate biological mechanisms of action behind how these exposures correlate to human health. And usually the underlying goal is to find treatments and cures for particular conditions. So from this type of research, we've actually learned a lot about air pollution and human health. We now know that the particulate size is actually really important in the types of bodily tissues that the air pollution settles in and damages. And as you can see, this study here was looking at the different kind of settlement end locations of the particulate matter and how that correlates to an increased risk of cardiovascular disease. Here's just another example, looking at respiratory illness and how acute exposure to air pollution can actually lead to kind of respiratory diseases like COPD, but then longer-term exposure can actually damage the underlying DNA and lead to cancer, such as lung cancer. But then the other type of science, which is more kind of closely aligned with what epidemiology does and what my research looks at, is observational science. And in observational science, you're actually more interested in what's going on in the world around us, not in certain circumstances that we might manipulate, but really the reality on the ground for different populations. And so we tend to do much more large-scale analyses. We're looking at the distribution of disease and which populations or people groups might be most burdened by particular diseases. And so what we're trying to do is generally to address those inequalities and correct those inequalities through either changes in policy, through public health, or changes in practice, and that's kind of clinical research. So here's one example of that kind of observational large-scale study. It was looking at the proportion of deaths that were due to lung cancer, stroke, and heart disease that could actually be directly attributed to air pollution exposure. And as you can see, according to this World Health Organization study, it's around a third of the diseases, or the deaths attributable to those diseases, are directly related to people being exposed to air pollution, which is kind of shocking. This is kind of another similar example, but this was looking at the regional distribution of premature deaths that were due to air pollution in the year 2010. And obviously any premature deaths are too many, but as you can see over in Central Asia, Eastern Asia, and the Pacific, those rates of premature deaths that are directly attributable to air pollution are really shockingly high. And then they kind of delineate here on the left the different types of diseases that are kind of the underlying problem, the mechanism through which that air pollution is causing the premature death, and that's through the cardiovascular diseases, respiratory diseases, and then birth defects. So for that type of research, that observational research, we're generally relying on secondary data sources. And what I mean by that is data that was collected previously by someone else generally and made either publicly available or available, for a fee on a case-by-case basis. And the reason we do this is because we're generally looking on this wide scale. We're looking at an entire country, or we're looking at, globally the differences in these disease kind of impacts. And so the feasibility of kind of sampling for yourself from distribution across that large of a region is just really kind of impossible, basically, based on our funding abilities and the number of people you would have to do so. So there's also ethical concerns. I should mention that particularly come up when you are looking at the exposures that we believe to have kind of a negative effect on human health. Obviously, it's unethical to expose people in a randomized trial or something like that to things that we expect will lead to cardiovascular disease. And so we really like to take advantage of these existing data sources to try to answer these questions. So it's not so much the fact that we use these data sources, but there are some problems that come up. And that's really because data are not neutral, and that's not always what we're taught, particularly here at Stanford, but it's really important to know that all data were collected by someone for a reason, and that person or institution has a particular worldview, and that all gets kind of embedded into the data. And so it's really important to ask yourself whenever you're looking at these data sources or using them to ask a new question, where the data came from and who maybe isn't being represented appropriately. And so there's this great quote by Nick Berriman, who's a statistician up in Canada, who says that data is always the product of cognitive, cultural, and institutional processes that determine what to collect and how to collect it. So I want to go through a couple of examples, both on the environmental exposure side and then also on the health outcome side, so we can start to think about, the ways in which this is impacting underlying populations and impacting our research. So for environmental exposure data, the primary sources of this data are through governmental organizations like the Environmental Protection Agency, NASA, NOAA for climate data, and meteorologic data, USGS, things like that. There are also some academic and scientific institutions that make data available that's really useful. And then occasionally you'll find kind of an independently funded initiative that's smaller in scale or smaller in scope and looking at a particular problem. And with this type of environmental exposure data, there's two primary concerns, kind of limitations that you have to take into consideration. One of them is the political aspect. So certainly with governmental organizations, even scientific governmental organizations like the ones listed there, you really have to question the research directives and the goals that were set by the administration. And the majority of these organizations also have at least a couple of kind of politically appointed officers at the top, which is not to say that they aren't doing great science and really making a lot of wonderful information available, but you do have to question the research priorities that they're setting. Also in the ways that that trickles down to the other types of sources. So a lot of academic and scientific institutions are actually receiving funding from the EPA or NASA, and it's not always immediately obvious, but by selecting which kind of proposals to fund, they are making decisions about which research actually gets done, which studies get conducted, and what gets looked at. And so that's really important. And then the other thing is there's just a difference in resources. So if you're looking geographically, you can see in poorer communities a lot of the time, or poor counties, sometimes poor countries, the kind of resolution of the data and the kind of the extent to which they have equivalent data across the entire region very, very much differs by resources that they have available to look at these questions. So this I just pulled a week ago from a Berkeley initiative called Berkeley Earth. They look at PM 2.5 air pollution concentration. And what should immediately be obvious is that there are huge swaths of the globe that we really don't have good data on from sources like this. They're just not reporting sufficient data for a variety of reasons, right? What should also be obvious is over in parts of Asia, certainly in the Pacific, we know that from previous studies that about 35 to 45% of premature deaths in that region may be directly attributable to air pollution. And so not only do we not have the data resolution that we would want from that region, but it's likely that the underlying data that we're missing is skewed to the high exposure side. And this is just a zoomed in picture of North America from that same map. I just want you to think about it for a moment, because in a couple of slides I'm going to show you some outcome data that kind of correlates interestingly with that pattern. So on the health outcome side, if you're looking at, say, cardiovascular diseases, we often get that data from electronic health records, which are kind of automatically generated every time you visit a doctor's office or hospital, if they have a computer system, which most do at this point. Health insurance companies can make their claims databases available to researchers on a case-by-case basis. And then we also have some kind of CDC and quasi-governmental organization-led initiatives like disease-specific registries, where you can find information on all newly diagnosed cases of cancer in the country. Statistics on reportable diseases, which are like communicable infectious diseases of interest, and then general mortality statistics. And the limitations on this side tend to be questions of access. So that could be physical access. People in rural communities may physically but be unable to travel to the nearest medical provider or something of that nature, so they might not be showing up in a lot of these outcome data sources. Or it could be financial access. So if you look at kind of the distribution of health insurance, say, for example, in this country, you can see that some people may not be visiting doctor's offices because they're financially unable to do so and they don't have that health insurance coverage. And then there are questions of visibility. So certain populations, such as indigent or homeless populations or undocumented immigrants, for example, don't show up not only in these data sources, but they're not in what we would kind of consider our denominator data. So in order to have a rate of some disease, you have a denominator that's all of the people that should have been susceptible for that disease in the country or state or whatever kind of region you're looking at. And because they're not in census data or anything of that nature, those people are, for all intents and purposes, invisible to our research. So here's just a geographic look at the health insurance rates from 2013. So this is before the Affordable Care Act. So this is improved, thankfully, but the kind of geographic patterns stayed pretty similar. And what's interesting is if you look at, say, Texas, for example, nearly the entirety of the state of Texas is 20% and above in terms of uninsured rate within each county, which is pretty shocking. And then if you're looking at actual cardiovascular death rates from the range 2000 to 2006, that dark red area in the middle we actually call the stroke belt in epidemiology. And what I think is really interesting is to think about this distribution of cardiovascular disease deaths in relation to that air pollution picture that we showed earlier. And you can see that a lot of the worst rates of cardiovascular disease outcomes are actually really highly correlated regionally with the air pollution exposures. So what does this all mean for the research that we're actually creating and publishing? You can imagine, and I'm sorry for including a scatter plot, I apologize, I can't help it. As a data scientist, we just love statistics, unfortunately. I'll try to keep it to a minimum, but basically you can imagine like if the x-axis is your exposure, and as you travel along you see higher rates of exposure to the right, and then your outcomes, say CBD outcomes on the y-axis there. So if this was the true underlying data, you can see that the red line is kind of the correlation or the estimate of effect of that exposure on outcome as you travel across the exposure range. But what happens, for example, if we don't have the highest rates of exposure because we're looking in a rural community that maybe doesn't have the money or the resources to devote to capturing this data on the gradient that we would like to have it? And maybe they're in a red state and they're less devoted to, let's say, environmental issues. But then we also maybe don't have the highest outcome data for that same population because of concerns about, they're an impoverished community that doesn't have good access, either physical or financial access to healthcare providers in order to enter into our kind of sample that we have. So what happens is, you can see on this blue line of what we're actually estimating, not only are we getting the effect estimate incorrect, you can see as you travel along that it gets kind of worse and worse for what we're predicting for the outcome for that population. But if you look at the people all the way on the right at the highest rates of exposure, we actually don't have any information about the effect of air pollution, say, on cardiovascular disease in that population at all. And so what that means is that we generally, in our research, just don't talk about those people at all. We consider them kind of outside the scope of our model, which is good statistical practice, but if those people tend to be a particular population or a certain demographic or geographically clustered in one region, then we might not have any information whatsoever about the effects that are kind of occurring in that population. And so what's the broader impact of that and publishing that? I would argue that one of the biggest issues is that we can actually contribute to exacerbating the problems in those communities. So in the best case scenario, organizations and governments are using the research that we provide in order to understand where to devote resources to address these inequalities. And if we're telling them that the largest problem is in the communities that we actually have measurable data on, then they may be devoting those resources to the worst of what we estimated, which may not be the populations that actually need the resources the most. The second issue, if you're less of an optimist and you don't really believe that people are kind of using scientific evidence to devote resources appropriately, is that we're really not holding governments, industries, and corporations accountable for the ways in which they're negatively impacting the health of communities. So that means that when those communities bring legal cases, for example, against a corporation, we have not provided them with the data that they need to back up the claims that they know are true because they're seeing them on the ground and they're experiencing them in their day-to-day lives. The third thing, which may not be immediately obvious for people who aren't as kind of familiar with the clinical world, but basically less on the public health side, more on the clinical research side, the work that we do tends to inform kind of the ways in which clinicians tend to be trained in medical school. And so chronic disease isn't really like infectious disease. It kind of depends, your disease course and your symptoms depend strongly on previous exposures to other diseases and your overall immune load and genetic predisposition for certain things. And so if we're not looking at a kind of broad cross-section of the population, and if we're not correctly characterizing what disease looks like that's related to, say, air pollution in those populations, then clinicians may be providing inappropriate quality of care completely accidentally to those populations. And all of those things really contribute to a warranted loss of confidence in the medical and scientific establishments by the people from those populations, right? So if you're familiar with the long history of, let's say, public health and medical racism in this country, it's very understandable that coming from that history and knowing that history, then seeing that they are not being represented once again in research, that communities that are already marginalized can see what we're putting out and assume that we basically don't have their back, that we're not appropriately trained to help them out. And they're correct in a lot of instances. So what can we do about it? I would argue that all research, public health research, medical research, should really be partnered and aligned with the impacted communities themselves. So if we are not in communication with these communities and talking to them about the problems on the ground, the problems they're experiencing and their concerns, then we're probably not asking the right research questions in the first place. The second thing, which actually addresses the first problem even better, I would argue, would be kind of the advancement of scientists and researchers from those communities. So those people are the best placed to understand the problems that their communities are facing and to ask the right questions in the first place. And so we really need to be ensuring that those people are taking the lead and are, appropriately supported in order to do this research themselves. And I would argue that, a lot of universities and academic institutions kind of like to say a bunch of nice things about diversity and how it addresses underlying inequalities. And that's true to an extent, but I think it goes a lot deeper, and I think it's really important that these institutions take the time to really think about what supporting people from a diverse background really looks like, and whether they are being financially supported, whether they're have the social support, whether they are not the only person in the room or the only person in their class. And those things are really important in order to ensure that they can succeed and really make our science better. And then the third thing that I think that all of us can and should do is to become critical consumers and creators of scientific evidence. So every time you read, the published literature, I would argue that it's not most important where it was published, whether that's Nature or Science, but really asking some hard questions about where they got their data and whether we think they're accurately representing the populations they claim to be representing. And so that goes back to this question. And I really think it's I probably could have just skipped the talk and just shown this slide, but unfortunately you had to sit through the whole talk. But I really think this is the important question, like who is and is not being represented in our data? And can we even answer the question that we claim to be asking?